Hey everyone, I want to share something that's really helped me recharge and refocus. You know how life can just get overwhelming sometimes, right? I found that taking a break to focus on my own well-being can actually make me more productive. And I discovered that firsthand at Mountainside Lodging and Retreats. It's not just a place to stay, it's truly a sanctuary for self-care. Whether it was taking peaceful walks in nature, cozying up by the fire, or simply finding some quiet time to reconnect with myself, Mountainside offers exactly what you need to reset and recharge. Now, if you're feeling like you need that kind of escape, here's the best part. Use promo code IWD406 for a very special discount this season. Trust me, you'll leave feeling truly refreshed, renewed, and ready to take on whatever's next. So if you're ready for a real break, use our code and book your stay today. You're listening to the IWD406 Podcast with your host, Julie Walls and Kate McLaughlin.
Today on the podcast, we have Dr. Deborah Hoffman. Deborah Hoffman, MD, is a provider at Logan Health Heart and Lung. She brings extensive experience in expert care focused on pulmonology, critical care, and sleep medicine. Her approach to healthy living is rooted in the balance of good nutrition, regular exercise, and restorative sleep. Dr. Hoffman earned her medical degree from the University of Miami in Florida and subsequently headed west for her residency and fellowship work at the University of California, San Diego, in internal medicine and pulmonary and critical care. She has a robust background in the study of sleep apnea and believes that identifying untreated sleep disorders can help positively impact patients' lives and reduce associated medical costs. She offers comprehensive skills to help screen, educate, test, manage, and track sleep patterns to alleviate sleep apnea, maximize wellness, and improve the quality of life for her patients. Dr. Hoffman shares her expertise as a medical director for Logan Health Outreach sleep medicine programs, providing this much-needed service to the greater Flathead community and Northwest Montana. Dr. Hoffman heeds her own advice and stays active and healthy as a long-distance endurance runner and cyclist, as well as a 4-time Ironman triathlete. Oh, man. Oh, put me to shame.
Yes. Welcome, Dr. Hoffman.
Why, thank you.
Thank
so
you.
Happy to be here.
I am too, man. I can't wait to dive into your background and being a 4-time Ironman triathlete.
Mm-hmm.
That's pretty
That's
impressive.
amazing.
Plus being on call at the hospital. Wow. How do you do it all? I just got to throw that out there.
I'm in a different phase of my life right now. So Ironman, the last time I did Ironman was probably over 10 years ago. But it is true. I was working full-time as a critical care and pulmonologist, doing clinic and training for Ironman, which was extremely...
That's a lot on your plate.
It was, but I can say for me, my mental health and my just sleep and my taking good care of myself is really rooted in exercise. And I just really love to go out and run for a long distance or ride for a long distance. I feel so good when I'm finished. And even
is it like when
it.
you say long, is it like I'm starting with 10 miles today, or what is... I don't know.
So,
because to me, a mile is long.
Yeah.
That's a long one. Running, anyway.
So this past October, I rode my bike from San Francisco to San Diego.
What?
Oh.
And so we ride about up to 100 miles a day.
Oh, wow.
So that's a big event. And then if I'm here, if I'm mountain biking, it might be shorter, but maybe 20, 50 miles, something like that.
Wow.
You know what? I think people would want to know, like routes, if you're getting into that type of training and what... Because some people they're new here and they're like, I love to bike. Where do I go?
That's actually a really good point.
Yeah.
Because when I came here, I've been here for 8 years. And when I first came here, the one thing I was frustrated with is there aren't really good bike lanes on the roads.
Right.
No, there's not.
And it's hard to get to...
A death trap.
Yeah, it's pretty scary.
It is scary.
So, and that actually helped propel me from doing only road riding to more about mountain biking and then gravel bike riding, which is where it's a bike with just a thicker tire that you can go anywhere up in the mountains on gravel roads,
Had you done that
forest
before?
roads.
Had you done that before? That's different.
No, I really hadn't. I mean, I did a little mountain biking when I lived in San Diego, but mostly road riding. So totally different.
Totally different. And who was I? You probably know this. All the ER doctors are like during mountain bike season, they see tons of contusions and it's not even the right thing to say.
That's right.
Contusions and
Hopefully it's not a broken bone.
Yeah.
yes, terrifying. I want to back up. Let's start with, where did you grow up?
So I was born in Rochester, New York, but I moved. My dad and my mom moved me pretty quickly. We moved to Miami, Florida when I was 4 years old. So I spent my whole youth in Miami, Florida. And then I eventually, it's interesting, my mom is from Philadelphia, and she and my dad met at Villanova in college. And I eventually went back to college in Philadelphia, which is where my grandmother at the time was living. So
Okay, good.
Did you hear a lot of good things from your parents about that area? Or did it just, maybe I'll go check it out for myself?
I think when I was, I think I knew I was close to my grandmother in Philadelphia. My grandfather had died when I was very young. And I always looked up to her as a role model, this very vivacious, very strong-willed woman. And so I think that was a big part of it. I was like, I'm interested in going to school near my grandmother. And
Nice.
Ended up in Philadelphia.
Wow. But you grew up in Miami.
I grew up in Miami, yeah.
So what was that like?
It was really interesting.
That's totally different. Yeah.
Yeah. Miami in the this is the 70s and 80s.
Yes, I love it.
And even today, it's such an international city. There are so many Cuban Americans that live in Miami, and I went to Catholic school, so most of my friends were Cuban. And in fact, I always like to think that it's because of my Cuban American friends that I can speak Spanish. My Spanish is not great, but I was so pleased recently talking to one of my friends. She's a second generation Cuban, lives here, and she said, I speak better Spanish than her two sons.
Oh, really? Wow.
And that's good because you retain it all too.
Yeah.
You've retained it all.
Yo necesito practicar español.
Oh, como no?
See, we should probably do a
Vamos.
whole. Yes, we should probably do a whole podcast.
Oh my gosh,
Like now
that
it's
would be
Española.
great. Will
It
Ferrell
would.
did a movie once all in Spanish. Will Ferrell, so we should do a podcast in Spanish.
I can only imagine because I
Es
think he's
posible.
Yes, let's do it. I love that. Okay, so then what sparked your interest into going into med school?
So I would definitely say my father. So I did have very strong role models growing up. One was my father, and the other I would say was my grandmother, and then later my mother. And I think at different times in my life it shifted. But when I was really young, my dad was the director of the infectious disease department. He was teaching in the medical school. He was seeing patients, and he was doing research. And then every now and then, the local newscaster would come over to our house to do an interview with my dad,
Really?
to be on TV. And I always remember thinking, oh, wow, that is just so cool. My dad is like a local expert in Miami for this whatever infectious disease thing that they had him on for. So I just noticed that and thought it was just wonderful. And then I think I started to show interest. So he would take me to work when I was younger.
Really?
And
In the infectious disease world?
yeah, and I probably didn't go in the hospital, but he took me to the lab. And I think even one summer, I answered the phone for his office.
Yeah, that's amazing.
So early on, I just thought it was fantastic. And he did everything, really, teaching and practicing medicine and research in an academic setting, which is just phenomenal. So I think I always looked up to that. And then my older brother decided to go to med school. And I feel like those things were all aligning. And I'm like, I think that's what I want to do.
So interesting. I used to work in the diagnostics world, and so here's what I'm thinking. So you were exposed at a young age and were probably taught that this is the human body, right? Whereas I grew up in a household that was everybody wanted to barf if they saw somebody's leg cut open or boogers or anything mucus. And when I worked for a pharmaceutical diagnostics company, we had to go in the pathology. And I remember just walking in and just holding my nose going, how do people work like this? But I think it's just this exposure piece.
And not only was my father a doctor, my mom was a nurse.
Oh, okay.
So you had medical field all around.
So my
you.
mother, another role model, first of all, she was in nursing, got a master's for nursing education, and then eventually had 5 children and was dedicated to staying at home and taking care of us. So she was a caretaker to patients and then to us. And then eventually, she is amazing. At 50 years of age, when we all had finished high school and probably college even, she went back to nursing. Got recertified. A lot changes in 25 years. Yeah. And went back to nursing and worked and I remember this so well because she went back to a refresher nursing school when I was going to med school. And we lived in the same house. So I just remember her with her little cards and her studying. And it was really impressive to see her do that, and very courageous at 50 years old to go back to your profession.
Yeah.
So caretaker her whole life. And now my dad has some medical conditions, and so she takes care of him. So her whole life has really been focused on taking care of him.
Caretaking. Yeah. My grandmother was a nurse until she retired at 75.
Wow.
She had, the uniform with the hat thing too. Yep. And the
like the old
apron,
school,
like the old school white hat. Not everybody wore it, but I think she was just like, no, this is my uniform, and it was hanging on the back of the bathroom door.
That's how I think of my mom, with the white tights and the white
and
shoes.
the white
She did have a little
shoes
hat, and I know when she graduated. Now I'll have to talk to her about that. But
there's something so special about people that go into those fields. It's such a caring, loving field. But then I think we can go down this road. I don't really want to, but we could go down it. But it feels so much. Nurses just don't get the appreciation and the respect like they used to.
And I've always thought it's interesting that people think doctors and nurses are the same thing.
Yeah.
But what their roles are in the hospital are pretty different.
Yeah.
And so, they're vital in very different ways. When I'm in the hospital and I'm in the emergency room or on the floor with a patient, there's a lot of things I can't do that I need a nurse to help me with, just with taking care of a patient. And sometimes we have plans, but they execute everything. It's interesting.
So I think it's interesting. Yeah. How intricate, how big of a team it is, and how they impact each other in that work situation, plus how it impacts the patient care.
Right.
Exactly.
It's so amazing. I wish more people would talk about that.
And there's more to care in the hospital. There's respiratory therapists who are really vital for a lot of things I do in pulmonary and sleep medicine. There's, phlebotomists that take the blood pretty much every day on patients.
I always like when I get a good one.
Right job. So there's the dietitians, like the people that come in and help patients with education while they're in the hospital. We do a lot of educating in the hospital. And then even our dietary, like having food that patients can and want to eat in the hospital. That's also it's a huge team,
and everybody has their own way of training and thinking, and then how you all come together to bring that together with your own specialties is pretty remarkable. But it does take some facilitation. You have to have somebody, a facilitator, like a hospitalist, that can be able to work all of that together for a plan to get the patient out of the hospital. And I think that's pretty remarkable. And I don't know. It's fun to go into the hospital and kind of see that happen. I don't want to be there as a patient, but when you get all the different people coming in, I'm like, how do you know that I need that? I talked to the other doctor, and you guys all, is that how it works?
That sort of, yes. I would say yes, it is. I would say while you're saying that, I was thinking, gosh, sometimes it's so hard with the coordination.
Yeah.
It'd be so great. In the intensive care unit, in general, it's an environment where the everyone working there is there, and they make rounds like as a team. On the floor, as a general medicine floor, as a hospitalist, you don't really have your whole team together to talk about everything. So the communication part is tricky. In the day, it used to be a pager, pager going off all the time, and then you'd have to get on the phone, try to figure out who called you. Now we have secure messaging, which is really nice, and you can include more than one provider and say, hey, here's the plan for the day on this patient, or include the respiratory therapist or the nurse. So that has gotten better, but it's kind of like a juggling act during the day.
Yeah. I want to back up real quick, and I want to go to what made you decide to go into your specialty when you went to med school?
Yeah. So my father, as I said, was a big role model. He was in infectious disease and internal medicine. So he started internal medicine. And I like when you're in med school, you don't really know what you want to do, but there's just some broad categories. I thought maybe I wanted to be a trauma surgeon for a little while. And then I was like, oh, that seems pretty stressful. But critical care is quite stressful too. But I axed that. I didn't want to go into pediatrics or obstetrics and gynecology. And then pretty much what's left over is like radiology and
Is it because
you determine it due
to the lifestyle, or is it just interest?
No, I did not choose it because of the lifestyle.
Because I'm thinking like
if I had it to do over, because critical care is really hard. For most of my career, I was on call every 3rd to 5th night. And I tell people it's like having a baby and you're up every 3 to 5 days in the middle of the night and it doesn't end. It's not like they...
I think my brother, he went to med school and became an internal med doctor and diabetes specialty. And I remember him saying way back in the day, I do not want to be an OBGYN. I don't want to be on call. I don't want to be at the beck and call. I mean, because you really don't have a life, right?
So I think people do have an idea. You're right. But I don't know that I did. I just knew, I think I was, heavily leaning on my dad. I was like, oh, he was in internal medicine and then he did infectious disease, which in Florida and Miami, where we have people coming in from all over the world in South America, it was really interesting the cases we would see down there. Yeah, tuberculosis, malaria, like some really cool things and things that we don't see up here. And so I think that's how it started. And then once I got into my internal medicine residency, again, I looked up to the people that I was just the most impressed with, that I think had the best personalities and were so go-getters, were the critical care doctors. And I felt like you walked in there and it was, between that and an emergency room, it's just like you are dealing with life and death.
Yeah.
And that to me was like, I want to do this. Like I was excited about it.
What about that made you, thank you, Kate. What about that made you excited?
Well, it made me excited to be able to help people, is to be able to stop that.
But it's such a
it's
drastic.
Yeah.
You've got life hanging on the line or they're going to die.
Yeah.
So how did you manage that, compartmentalize it in your brain?
Mm-hmm. I'm not sure I have an answer to that. It seemed to come pretty naturally. I never thought, oh, how do I deal with this? I think I saw residents who had trouble with that and I didn't have any trouble with it.
Because in your mind, are you procedural? Are you like, okay, we did this and this. The outcome was still going to be this.
Yes.
Okay.
So I think that's right.
And I think you have to have that type of brain to be able to work in that type of field.
And say, I've done the best I can and that's where we're at.
Right.
Even, so you don't have... I would assume I don't have guilt attached.
Or even beyond that, like this patient is dying. Yeah. Based on whatever our experience is with our training, there's a 90% chance this person's going to die. How do I help this person transition, in a respectful and wonderful way? Right. So that the accepting of death is not a failure, but a normal part of life. We all are going to die at some point.
Yes. Yep.
So accepting that and to be able to say, I can help people get better that are going to have a reversible condition. If a person doesn't have a reversible condition, sometimes we still don't know. They might be dying today. They might be dying in a month or 2 or a year. We don't know. So it's just, I think, being involved and reversing some of that life-threatening situation is exciting, but also really being able to help people who are dying is also quite rewarding. When I started in medicine, we really did not have hospice or palliative care. Those are specialties now that have been...
So did you have to take on that role?
Yes. So in critical care, we did do all the end-of-life discussions. And also, just statistically, if you're in the intensive care unit, there's a certain % chance you're going to die.
Hey, everyone. I want to take a moment to tell you about an incredible place making a real difference, Two Bear Therapeutic Writing Center. This is an organization committed to creating a truly enriching environment where people from all walks of life can discover, learn, and grow. Their programs go beyond just activities. They truly offer meaningful experiences that enhance emotional well-being, promote independence, and build valuable skills. Whether it's through pediatric physical therapy, adaptive horsemanship, which I love, engaging summer camps, or the full ranch experience, which is breathtakingly amazing, Two Bear has something to help everyone thrive. Their slogan, Therapeutic for All, captures who they truly are. At Two Bear, every participant, volunteer, staff member, and supporter is considered an integral part of their community. So, whether you're looking to get involved, need support, or just want to learn more, come see how Two Bear Therapeutic Writing Center is changing lives. To learn more, visit www.twobeartrc.org. Join them in creating a space where healing and growth happen every day.
By virtue of the fact if you're on a life support machine, that means you wouldn't most likely you wouldn't be alive if you didn't have that machine.
Right.
So there always is going to be some percentage of people in the intensive care unit that are going to die. And that's part of their natural life. And so I don't think I really struggled with it. I found it to be something that I was good at, and I felt comfortable with it, and it was pretty natural for me. So I embraced it.
How does that work with the families when you're dealing with your patient? How have their interactions with?
I would say it depends. I think the weirdest thing about American culture is that we're prepared for everything. Most people, like, you don't run out of gas every day in your car. You plan for your kids to go to college. You make sure your bills are paid on time. But it is interesting how so many people in their 80s and 90s still haven't even talked to their family about end of life or what they want or what their wishes are. What would I want? And maybe because it's hard for people to talk about. But it is very interesting to be speaking to a person who's looking at me and say, what are your wishes? And they either don't know, or it's hard for them to talk about, or they immediately look at their children, the person in the room, to defer and have them make the decision. And I do remember years ago, a palliative care nurse had said to me, I think we should make it mandatory. As soon as you enter Medicare at age 65, you have to sit down with a palliative care person and talk about end of life. And I was like, that's a really great idea.
Because then you can't be in denial about it anymore.
No,
that's
I
right.
remember when my husband and I were working on doing the wills, it took me like probably a year before it actually got done, just because I didn't like thinking about it. Yeah. Okay, I don't want to plan when I'm not here or to figure out how my kids are taken care of, because it's a hard thing to think about. But once you do, and then once I did and got that taken care of, it did feel better. Okay, now I have some control over it. I know that my children will be taken care of and this, and it gave me a better sense of calm than denial.
Well, and I have to say too is, I think the idea that, if I make a decision now, it's irreversible, is also not at all what end of life discussions are. You can always change your mind.
Yeah.
You can, if something happens, and again, I like to go back to that reversible and non-reversible reason you're in the hospital. If it's something that we can fix and you can get better, then there's really no question about what we're going to be doing for you. If we deem that the illness is on a trajectory and it looks like a person's going to die, then that's a little bit different. But people can decide to change their mind too. We have that happen all the time.
You mean change their mind to die?
About what they want near end of life.
Okay.
In a way, you're not going to ever change that, but you can prolong a person's suffering by putting them on life support.
Yes.
Mm-hmm.
And so sometimes those things do happen and they change. And then sometimes, even when a person's on life support, the decisions are made again and we withdraw support, which is really hard. And that's really hard on the family. Mm-hmm. So that's why when you're asking about the family, that's why it's so great for all of us. I had years and years ago in San Diego, a young pregnant woman had a condition that was fatal. And they delivered the baby and the baby was fine. But after that happened, she was in her 20s.
Oh.
But after she died, I called my parents and I was like, I just want you to know how I feel about, because at any age something could happen and here's what my thoughts are. And so we had a little discussion. I was probably like in my late 30s. I wasn't very old. And I talked to them about it and also had them talk to me about it. But I find it interesting that as a culture, we just don't talk about that.
Yeah.
Even in families. And
I think the other piece, I'm going to throw this out there, and I want to get into that specific case. You're not a robot. You have to somehow take it with you sometimes. I want to know, but first I want to ask you or talk about the fact that I think there's also a denial factor, and I'm going to throw this out there, and I may be causing some controversy, but I think some people are like, I'm not going to die. I'm not going to die any soon. And if I do die, what is that going to mean? And then my kids are going to be affected. And I think it's already hard enough that you're going to lose somebody physically. And if you don't maybe not have a spirituality base of something's beyond, or you're going to go to another level, or whatever that looks like, or you're going to turn into a tree, or whatever that looks like, right? So you're at that end of life stage.
So I really do think this is a great topic. And I would say too, as a critical care doctor for 20 years, I do have experience with end of life, much more than most regular people. And then, of course, even in the hospital, a lot of the providers don't deal with end of life. So the one comment you just made was, as a person is dying and they're deciding what they do and they don't want, withholding food and water might seem horrible. But the truth is, when you're dying and your organs are starting to shut down, one of the things that doesn't work well is your stomach. And so if you're putting food and water into your stomach, sometimes it causes people to feel sick, bloated, and even vomit. And if they vomit, they could aspirate and then die from pneumonia. So you could hasten it. So actually it is not miserable to if you're in the hospital and you just woke up from a surgery, all of us are like, oh, I'm so thirsty, give me water. But no, not at end of life. Not necessarily, I would say. And that's another very interesting end of life dilemma, because you've got family members that are like, Dad hasn't eaten in 3 days.
Yes, they freak out.
And he hasn't had a bowel movement. And you have to say, but his body isn't working like it was when he was vital and living normally. So it's just different. And
I think that's interesting that you have to also contend with all the people that are the family members that are they're not as educated as you. They're not aware. Maybe they've never been around somebody that is dying.
And they're emotional.
Yeah. And it's like, why wouldn't you, as a person that, okay, I think, again, everybody should have some sort of plan in play, even if you're 20 years old.
Yeah.
Because to say, okay, this is you're going to have to expect this when I'm dying. And if I'm in the hospital or if I'm at home in hospice, this is what I want. And make sure that it's clear. It's clearly defined. And
living will, right?
The living will. Yeah. And I know people do that. But I don't know. I just think to myself, I'm like, I think it's so important. And then on top of that, you're right. How we view death is so different here than it is in other countries. Yes, we're going to lose that physical form, right? But it's a celebration. Like, they're no longer suffering. Why don't we put those parameters in play? Why don't we talk about those pieces and change the rhetoric around dying? And you as physicians probably see that. You're like, yeah, they're no longer suffering. I'm helping them to no longer suffer.
And going back to the comment about putting things into a will, it also isn't putting things in a will is fine, but if the patient hasn't talked to their family members, and you got family members, the patient's unconscious and the family members are there, it is so stressful for them.
Oh, I bet. And then family members don't always agree. So I'm sure there's a lot of that going on too. Right. No, mom would want this. No, mom would want that. And that just increases the stress of everything, I'm sure.
It does. And I've seen all sorts of different variations of conflict and who's going to make this decision. And in the end, it's always good and important for us as the providers and the team, the nurses and everyone involved, to also help them with their decisions. If there is a decision that needs to be made, let us help you with that in whatever way we can. Mm-hmm. Here's what we think might be the best way forward. But being very cautious about not causing more conflict for them. Because, I think before we had palliative and hospice care in the hospital, the end-of-life discussions that we had in the intensive care unit, they usually are very long. They can be very long, and it's very emotional. And we are going now back to the comment about, like, how do you carry that? And it's true. I think every single time I would always think, oh, I'm pretty resilient. I'm bulletproof. I'm going to go home and I'm going to be okay. And what happens over the many years is then you find yourself where I did, which was complete burnout, where I was crying in the hospital. I'm like, what is wrong? What's wrong with me? I've been doing this job for a long time, but I feel exhausted. And I also, everything's okay in my life. Why do I not feel happy? I even had people say to me, you're a doctor, you've got this great life, and how can you not be happy? And I was like, I don't know why I'm not happy. Why am I not happy? And it was the beginnings of the burnout, which mine was really hard because I didn't, even though I knew what burnout was, I didn't recognize it in myself.
And maybe you're thinking, as a strong woman, I'm just going to put words in your mouth, but I'm strong. Why am I falling apart now? I've held it together for so long, and
what is this coming out of me? Like, I don't do that.
I mean, you have to, because as a critical, how long did you do critical care?
I did it while I was still here. So I started my practice in 2001, believe it or not. And I was in San Diego until 2016. And then I came up here and I still did a few more years. So about 20 years or so. And
That's a long time.
It is a long
Yeah,
time.
it is a long time. But I think there's so many things to think about or talk about. One thing that would be is how you recognize burnout and what you do about it ahead of time. The other thing would be how do you prevent burnout? Like how do you, I guess that's the same point, but if you're getting already burned out, how do you start to change things so that you don't have a complete meltdown, which is essentially what happened to me? Or how do you prioritize things that make you happy with your life and you can continue going on? I think one of the things, and this is also hard to say and will be hard for people to hear, is when year after year you're taking care of patients and there is, in some cases, the patients you realize they're not going to survive, but yet we're still doing everything to keep them alive. It can be quite frustrating when you feel, and you've already educated the family and said, hey, I don't think this is going to have a good outcome. Maybe we should consider not doing some of these things. That's really stressful for family and us and the care team. And that's a really tough thing. And I think there are times where, I walked into a room many times where somebody was barely breathing and they were about to die. And I stuck a tube into their throat and into their lungs and they didn't die. And that's amazing. But I don't really remember that as much as I remember some of the more difficult situations where it was so hard and a person was dying and there was nothing we could do. And yet still you almost felt like family is a little angry about the death, and maybe it feels like it's coming to the care team, to all of us.
Yeah.
Yep.
But
When they're mad at death, they're just they're shaking it on
And
someone.
there's so much that's complicated about people's lives. Maybe they hadn't talked to their parent for a while before they became unconscious.
right.
Maybe they had a
Yes.
falling out. So many other bizarre machination of how end of life could be very difficult for the person that's there at the bedside. I also remember a long time ago, a little lady was standing at the bedside of a man that was very sick, and they must have been in their 80s. And I swear, that woman stood there for probably a half a day, just stood at the bedside, and everyone kept saying, you need to sit down. And she just couldn't sit down. And that also reminded us, too, as a care team, is that not only are we taking care of the patient, but sometimes we have to also be on the lookout for the family.
For the family members,
yes.
Because if they stop eating and she could pass out, or she could, and she just would not sit down. She could not sit down. She had to sit there with her loved one.
So what do you think, looking at it from this angle, right? And I want to get into the fact that as physicians and as coaches, as psychologists, you're taking on people. You're taking on their energy, everything else. But what I think too, is there something in play where end of life is coming in, right? And you've got all this going on. And as a doctor, you're trained to take care of the procedural process. Psychologically, I'm sure you got training as well. But there are specialists out there that can do that. Do they bring those people in and be like, we need those people, they need to be here every single time?
You mean like psychologists?
Like a psychologist or trauma expert,
no.
trauma informed. We need that. There's nothing. They put that all back on you.
Yeah.
And as a physician, I can see you taking that on because I'm used to procedural.
I think things are changing.
They're changing. Okay,
I
gotcha.
do think things are changing. Even if you think about the generational difference between my father as a physician and me as a physician now getting close, into my career compared to the newer doctors. But I do think that's changing. I also think that the whole focus on checking in with yourself. Am I okay? Am I doing okay? Am I taking care of myself? When I told you guys I would do all this endurance sports, and it was really a way for me to just
Check out.
Yes.
Just focus on nothing but one foot in front of the other.
I think I'd be
pedaling.
thinking about something, but I would also.
But it wasn't
You're
stressful
doing,
thinking.
Right.
You came from doing to doing something else.
Yeah.
And not really the in-between of analysis, which is where I'm at.
Good point.
Where I feel like for myself, the whole burnout piece, I've been here before, I'm here back again. And it's like that in-between space of I've been doing, okay, I'll just dismiss or ignore the burnout things that come up. For me, it's more of waking up in the middle of the night, frantically going, oh, did I forget something? Or, oh shit, I didn't do enough yesterday. Or ruminating on a conversation. I'm like, should have gone differently maybe. And is that going to be reflective on my IWD406, right? So all those pieces start creeping in. And then I just go, oh, okay, tomorrow's a new day. Let's just start doing again. Let's create, and Kate knows this, right? But we don't sit in that in-between zone of what we don't somatically connect to, I'm feeling breathlessness. What the hell's that about? Or I'm having a little bit of a moment while I'm at work and I'm just finished up with the patient and why do I feel this lump in my throat? I don't recognize it. I got to go do something else, right? Is that where you found yourself, that in limbo state where you're like, I don't know what to do with this. I'm not used to this.
And it's funny because as you're talking about this, I'm totally smiling because I am still struggling with that, ruminating on things at night. Yeah. And my life now is not as stressful at all. But I still do the rumination thing, and I am getting a little better. It's like Scarlett O'Hara. I'll think about it tomorrow. Like the famous line from Gone with the Wind.
Darn her.
I'll think about it tomorrow.
Yeah.
But that is a strange, dismissive coping mechanism. And before, though, I just don't think I ever did that. I just never, it was building up and building up. And I think the easiest way to explain why it happened to me was, I'll keep going back to the normal process of our lives ends in death. Mm-hmm. If our community is just everyone who's dying has to go to the hospital and be put on life support and kept alive, which remember at the time I wasn't seeing the people that came in and said, no, doctor, I'm ready. I've made my peace with everyone. They're accepting and they go into hospice or they don't come to the ICU. That's never what I saw. I saw all the people who either the patient or the family were panicking and, oh my God, save dad, save mom, or whatever.
Yeah.
And so I just remember thinking a lot of this was so like, it hurt me that we were doing this to people that were in the process of dying. Mm-hmm. And they do suffer. They have tubes in their mouths. We have to sometimes restrain them. They're getting all these IVs. They're getting stuck every day to get their blood draws. Yeah. They might be getting tube feeds or feedings and their stomach isn't working well and then they're throwing up or they're bloating or having diarrhea. Like all these things that are just horrible.
And I want to point that out. You just pointed that out. You experienced trauma. You were literally sitting in front row of a movie of trauma. And I think that's why I hope this conversation hits a nurse or a doctor or a caregiver that you have to do that. That's not normal life, but somebody has to do it, right?
Somebody has to do it, or there's other things to think about. Like now with hospice and palliative care, I definitely think it's changed. Like people come into the hospital and they have terminal cancer. Oncologists in the clinic are already saying, hey, I'd like you to go visit with our palliative care because we want to just have a plan for you. And often patients are so receptive. They're like, I don't know what's going to happen. I don't know how this is going to end. And they want to talk about it or they want to have plans for it. Some people don't, but a lot of people do. So I think some of that has gotten better because we're able to help people with palliative care and hospice has just been a huge change for the critical care doctors.
Yeah, I can
that
see
must
that.
be a huge relief even to the patient,
though. How do you feel about that?
Right now I'm being bombarded that, okay, I won't say that they all say this, but death sentence, whatever. I have a limitation and I know it's coming up soon. And then you deal with that. And then what do I do now? You can keep ruminating on that. Or it is nice to have someone extend a hand and say, these are the steps you can take. And this is how you can help take care of yourself and your family or something that way. It's if you're going to a maternity nurse or having a midwife. These are things that are happening.
Absolutely. This may sound a little silly, but I swear, I think too, if you look at the personalities of the critical care doctors and the personalities of our hospice service, like I'm in there and I'm like, okay, what are we going to do? And I'm still, let's get this done and this done. But the hospice docs come in and they're like, hi.
They're so like, hey, they're like mellow.
They make me like so much more calm.
Yeah.
And they like, let's talk about like, how are you feeling today? Like,
I love that.
Yeah. Let's talk about how you're feeling today and what's going on. And they have they have a strategy about how they talk to the patient for the first time and every time after that, where they pick out the big parts. What are your real wishes? What do you still need to do in your life? How can we
those
make
are great
you feel?
Questions there too.
Do we need to make videos for you to give to people? Things that you don't even think about. Wow.
I love that.
Yeah, for your legacy and for just so that you feel like, okay, I check the box. I have been in the emergency room so many times admitting a patient and they're like, I can't stay. I have 4 dogs at home. Or there's something they have to get home to go do. And they're just so stressed out because they're sick with something, maybe not dying, and they just can't even focus on it because they've got to go home. That happens not infrequently that someone's, I can't stay. I got these, or I take care of my wife. She's bedridden at home and I can't stay and not take her. So these are the things that are going through people's minds that hospice care will come in, or palliative care, and they will just be like, hey, let's start checking the boxes and make sure that we've addressed everything.
I'm glad
so that you're
hear
not
that.
worried.
Yeah.
And you can relax.
Yeah. And I want to go to you. After all of this, and you started to recognize things of burnout, what did you do?
What happened, and the best way I can describe it is, I think I felt like I was saving people's lives, putting them on life support, and working in the intensive care unit, despite the fact that some of them were going to pass anyway. And I didn't think that their end of life was what perhaps they wanted, because oftentimes we hadn't discussed it. And so I was bothered by that. I was like, is this the right thing? Yes, I'm getting paid to do it. And I could just be like, oh, this is what I do as my job. Like you said, you're a robot. You just do your job. But I was like, I don't know if this is the right thing. If a person has a terminal cancer, and I can give you examples, but not making decisions that in the end, there are a lot of things I don't know. Like, I don't know when someone's going to die. I don't know, how much time most people have left. But we got clues. There are things you can look at, like blood pressure, and just there's a whole little list of, okay, if they check these boxes, they have hours to days to live or whatever. And so I just really was struggling with that. And so what eventually happened was I did find myself going to work. I was in San Diego, and I was going to work, and I would just start crying at work. I would just start bawling. And I genuinely was like, what's wrong? Like, why am I've got a nice house. I got great dogs. I'm an athlete. I'm a single person, and I like being single. So it's not what I was always like, oh, is that the problem? But I kept thinking, what's going on? Finally, I think this is hard to explain, but somehow I ended up in my car and I drove to Montana. So I was living in San Diego, and I decided I'm broken. I don't know why I'm broken, because everything's fine, but I need to take a break. So I took 2 weeks off of work, which was really unusual for me. Like, taking 2 weeks off and leaving your practice and all that was a big deal. So I drove to some event. I also do a lot of charity work for the Challenge Athletes Foundation out of San Diego. They are an organization that helps disabled people get back into sports or get into sports by raising money for like prosthetic legs and stuff that are really expensive. And some of their athletes are like hot, like para-Olympians, and just amazing. So they motivate me. And so I remember I was at an event somewhere in Napa or something, some kind of cycling or triathlon event. And I was just the medical doctor. I was just there as a support person. And I was still like, the cloud was over my head, and I'm like, I'm heading to Montana. And I don't know why I decided to go to Montana. I know I had a friend whose dad lived there, and I always thought, oh, it's so romantic. It's like the cowboy hats and like the Big Sky place. And so I just drove here. And when I got here, I decided to go to Glacier National Park. And I do remember one of the first days I was in Glacier, I could not get out of my tent. I woke up and I just couldn't move. I was so just broken and sad and could not figure out why that was. I also had a little bit of a relationship that was starting to develop that had already failed. So this guy was just not good for me. And so that was part of it. And I kept blaming it on that. I'm like, oh, it's that. I have a breakup thing. But then I just thought about it more, and I'm like, no, I don't think it's that either. So on my way back through Kalispell, I did have one person from San Diego that I knew who was living here. And the only reason I knew is because I was on Facebook at the time, and he saw that I was here. And I'm like, oh, I should probably reach out to him. And so I did. And he works at the hospital. He's a physician's assistant, Tabo Sato. And I was talking to him, and I cannot explain, but by the end of our conversation, these words came out of my mouth. I said, do you know if they're looking for a sleep medicine doctor? Because I was hoping to transition out of critical care and do sleep medicine, and they're pulmonary and sleep related. It's a kind of funny way to go. But I was like, I'll start working on sleep patients, because I was already doing it in San Diego. And he said, hold on, I'll call you right back. So he called me right back. And the next day I had a interview with Valinda Stevens, the CEO of Kalispell Regional at that time. I showed up in flip-flops, a maxi skirt, and a T-shirt.
Shut it.
I spent 5 hours at the hospital. They were taking me around. Everybody was just wonderful. They also asked me a lot about not my job, a little bit about the job and what I do, but what do you do for fun? Like, they asked me about, I realized, oh my gosh, the community up here, the doctors, genuinely care about their mental health, my mental health, and like they want to know what I do out of work. That was really unique for me. And I tell everyone it took me so they offered me a job, and I tell everyone It took me 2 days of hand wringing, but I think it was 2 hours.
Gotcha.
Yeah, I was I'm not married. I don't have to convince someone to come with me. Yeah. I think I'm going to move to Montana. And I called my brother first, and I said to him, "Don't say anything. Just listen to me," because he lived in San Diego. So one of my brothers followed me out to San Diego and had kids, and I'd been at both of his kids' births. I've known them since they were 0 years old. And I said, "Don't say anything," because I didn't want him to say you're crazy, and I didn't want him to argue with me. And I said all that stuff, and then he listened and said very slowly, "Deb, I think you have to do this."
Yay. Validation. I'm going.
I know. And then I called another coworker and I told them. And it's so funny when you move away from a big base, because some people are genuinely upset and don't know how to express it to you well, and actually almost shun you for a little bit. Like I've had some people who couldn't understand it and were mad. And then, interestingly, some of those people were going through the same things I was going through. And a year later, when I finally moved here, I started my job here. I did a little critical care, and then I finally got out of that, then did a lot of sleep. Then COVID happened, and I went back to the hospital as a hospitalist. So it's been a funny way, but I really like what I'm doing now. But after that initial, I'd say 6 months to a year, I had, I think, 2 or 3 other women call me and be like, "Hey, I want you to know, because of you, I quit my job and moved to somewhere." And I also have my sister. It was also hugely important because she taught me that I wasn't quitting. I was changing.
Yes.
So that was a big thing too. I thought I was failing and quitting, and I wasn't. I was just changing.
I love that. I love that. Because I think sometimes we attach ourselves to our what we do professionally, right? And that becomes our identity. And then it's the second that we see there's some toxic type behaviors happening, and then we're like, okay, this isn't filling my cup up. It's actually depleting me. And then you shift. It's okay. I failed at that. That didn't work out. I didn't do it. And then, but you're actually going towards something that's absolutely beautiful for you.
But when you don't know what it is,
right,
that's
it's
scary.
Oh, that's scary. So you get 2 scary things.
Yeah,
you do.
So, and I remember when I was still in San Diego, there were 2 things driving me that were hard. One was ego. So when you join a practice, and this is not how it is these days, but when you join a practice, a law firm or a medical firm group, you join and you stay for life. You don't leave or go away. Like you just stick with your job. You're part of the establishment. So I had that ego problem. And I remember even when people would leave our medical group, we had a big multi-specialty group, people would be like, you almost felt like
they abandoned ship.
Or they couldn't hack it. They couldn't hack it or whatever. Yeah, I made that all up. That was all like my perception. So ego is one thing. And then loyalty. So I felt loyalty to my patients, but even more so to my partners. Because if I left, then they would have to find a replacement, and there might be a gap. And I always thought there shouldn't be a gap between when I left and someone came. But I was so broken by the time I did leave, there was a gap. Yeah. So, but yeah, it's.
But at the heart
But
of
that's
it,
a brave thing to do, and say, I'm going to take care of myself. And I see the sunshine over there, and I'm going for it. And it's good to do that. And then, scary or not, you seem a lot better than from what you were describing before.
I am a lot better.
So.
And do you know, I moved here I came here on April 13th in 2016. And I remember for weeks, I would wake up at 5:30 in the morning. It was still dark in April. And I couldn't get back to sleep. I was so excited. I was like,
that's a great way to start.
I love
get
that.
out of bed.
The joy came back. I love that. So now you work in the sleep study. I didn't even know that even existed here. There's a sleep study.
So we have a sleep program
department.
at Logan.
Okay.
Yeah.
Gotcha.
And I actually oversee not only Logan, Kalispell, but the outreach sleep centers too. So several sleep centers in the state. There's actually
Are they
4
different?
of them.
So different counties and everything.
Yes. We have one Logan system has Kalispell, Shelby, and Conrad. And then Cabinet Peaks is out in Libby. So I oversee all of those. And then with our merger with Billings, they also have a sleep center. Right now we're still doing separate entities, but the idea is to just become this huge super program. So sleep, changing subjects completely, sleep is hugely important.
Yes.
So I always tell people the 3 pillars of good health are getting enough sleep, eating right, and exercising regularly. So those are really important. And when you come to the emergency room and you see the people that are in the emergency room, I always am like, gosh, I talk to people who broke their hip and find out they're not exercising. They're not taking care of themselves. They're weak. Yes, we can all fall over and break something, but you think, keeping active, staying active, well into whatever age you want to live to, eating, that's so important. Oh my goodness. And then sleep. It hurts my ears when we heard in this last campaign election series, someone kept saying, I'll sleep when I'm dead. And I'm like, no, don't say that.
Don't do that.
That is not a...
You'll be living dead.
That's not a good motto. It's cool. I get what you're trying to say, but no.
Well, and I want to ask you, as we age, it's okay to nap, right? It's okay to add more sleep in your day. What's your thought?
First of all, as we age, we sleep overall less, right? When you're a baby, you sleep all the time.
Okay, gotcha. Yeah.
When you're a teenager, you sleep a lot.
Oh, yeah.
When you're a 20-year-old, you sleep a lot. Some people can still sleep up to like 10 hours a night. I know when I was in college, I was still sleeping a lot. I intentionally took late morning classes, so I didn't have to be there at 8 o'clock in the morning.
Yeah.
As you age, your total amount of sleep time is reduced. That doesn't mean you're refreshed. It just means that your body is only able to sleep lesser and less. Probably 7 to 8 seems to be what we think is normal for most adults. But as you get older, it can be less. Mm-hmm. And I had this is so cute. I had a 96-year-old man come to see me like a few years ago here. And he was going to bed at 8 and waking up at 1. And he said, my doctor's worried and gave me a sleeping pill. And I'm like, oh my God, that's dangerous. If you take the sleeping pill and then get woozy and fall over, you can break your hip or whatever. And I said, how do you feel? And he's like, I'm awake at 1. I'm living with my daughter. I'm just there at the house awake. And I go, but how do you feel? And he said, I feel fine. I'm fine all day. I don't think he was napping. And he said, doctor, what's the normal amount of sleep at this age? And I said, I have no idea.
Yeah.
We don't see 96-year-olds, especially men. So I don't know. And I think you're fine. I don't think you need a sleeping pill as long, I don't think there's something wrong with that.
Yeah.
So people can also develop sleep patterns that might be, there is a lot of thought that sleeping 8 hours a night was created by industrialization, so you could get the most out of workers during the day.
Interesting.
In Europe, they still have siestas where you take a nap during the day and go back to work late at night. But there's an idea that, if we want to get our workers the most out of them, let them sleep at night and then work them 12 or 14 or whatever it was in the beginning days. So I think it is true, too, though, that consolidating your sleep into one session, if you can, is probably beneficial. The longer you sleep, the more REM, which is the deepest and the dream stage, and the more restorative sleep you should have with longer sleep. But everybody's a little bit different. And if a person came in to me and said, I'm napping during the day when I'm driving a bus, that's a problem. Yeah. But if they're like, I'm laying down for a nap and I like my nap, I feel good when I wake up, and that's just my pattern, then there's not a problem with it.
Nothing problem with it, yeah.
The other problem with us, too, as women, is there's definitely, once you're hitting menopause, there's so many more your sleep is more stuttered. So there's more awakenings, and that's completely normal.
Oh, God, thank God.
Definitely like, I'm sweating. I just rolled over and I woke myself up.
I'm sweating to death. Yeah.
And then people will talk about getting up to go to the bathroom and how many times is normal. And they've done surveys to see what most people say. And I think in general, getting up to go to the bathroom once or twice is probably not very abnormal, especially depending on what you're doing right before you go to bed. If you're drinking a ton of water or tea or coffee or something with caffeine in it, or prostate problems. So I think everyone's a little bit different. It is unrealistic to think as you get older that you're going to have normal 8 hours. I have had people come in and they're like, I'm not getting my 8 hours.
Yeah, they freak out.
And totally. I'm going to die. And it's, yes, we're all going to die, but probably not. We think that going under 6 hours regularly is not good for your heart. That's not a good thing to do. When I was in San Diego and I was seeing it was more of a younger population, I could not believe how little most people reported sleeping. They almost always said 5 to 6 hours a night, adults. And I was always like, how do you survive like that? I'm more of a long sleeper.
For me, it's 6 hours. And if I wake up early, I count on my fingers. Did I make it to 6? Okay, now I don't have to force myself to try and get back to sleep. I'm like, okay, I'm awake. I'm done.
Yeah. So that is impressive. And there's some people are just short sleepers. That means they can sleep 5 to 6 hours and they feel fine. But a lot of people that are saying they're sleeping 5 to 6 are coming to me because they're not fine.
Oh,
so they're
like,
tired.
No, I want to be sleeping. Yeah.
And the number one problem with sleep in the whole country, in the world probably, is not any sleep disease. It's lack of sleep. It's not sleeping enough. So insufficient sleep time is huge. And remember, in life, when you're waking up early because you got to get up and get the kids to school and get things ready before school, then you got to go to work, then you're coming home, then you got to do whatever duties and chores or whatever. It just keeps crimping the amount of time you can sleep. So I think there are some people that are short sleepers and they're fine. There are some people that are long sleepers, and I was always a long sleeper until menopause, and now I'm a in between, and I wake up all the time now.
And I also think too, the thoughts come.
Oh yeah, and anxiety.
Anxiety.
I had my burnout, and I now have anxiety, but I think I love that thing that we both nodded our heads on about before. I think now too, I'm able to do, oh my God, that email I sent, maybe I should have worded things differently. And then I'm like trying to do, hey, think about that tomorrow.
That's what I do. I tell myself, like, everything can be solved in your dreams. And I've taught myself how to shut down. That's like, awesome. No, you have to, So that's why I can sleep, because I'm like not getting disturbed.
And my husband's great at that. He's like, it's time for bed, shut it off. And then he wakes up and I slept 8 hours. I'm good. And I'm like, I was up all night writing journal thoughts.
My husband's like you. He does the same thing. I didn't sleep at all last night. And, his brain's going.
But for men and women too, there are some interesting differences. One is that in general, but not always, men fall asleep quicker than women. And so when women come into my office to have a sleep evaluation, they'll say, I feel this way. I feel tired or fatigued. They'll give me their symptoms. Men come in because they fall asleep earlier, come in and say, my wife says, because she's still up.
Oh, right.
That I snore, or I stop breathing, or I whatever, or I kick, or whatever. So I always find that really interesting. And then
that's interesting.
Half of the time, or it seems like not half of the time, but some of the time the gentleman will say, but I don't think I do that. And I always say,
do you think she's lying?
I know. I said, why do you think your wife would say that? She's probably a really smart woman. You're here. But I always commend the woman for telling them. But sleep apnea. So we talked about insufficient sleep as being the most important or most common sleep disorder, not getting enough sleep. And that really does mean like you can sleep more than 6 hours, but you're not because of your lifestyle, and which
I would love to hear from, because I want to get into your fitness and everything that you've done, because that's so important. Go ahead, keep going.
That was the number one, and then number two is insomnia. Okay, so insomnia is huge, right? Yeah. We all get stressed. We all sit there and think about the email or whatever, and you can have trouble getting to sleep, which is sleep onset insomnia, and staying asleep. So you wake up and then you start to think some more, and you're up for an hour during the night. And so most people have both of those things. And insomnia, I've gotten very good talking to people about insomnia. That usually takes me about an hour when I first see a patient with insomnia. But there's a predisposition to it for sure. Like some people are more prone to it than others. There's a precipitating thing that happens. Your house burns down. Your kid gets into an accident. Your mother dies. Like usually there's something that precipitates it. And then the problem, those things are not reversible, but the perpetuating part is the thing that we can work on.
Yes.
So that's where you are so worried about your lack of sleep, and then it becomes a self-fulfilling prophecy. Yes. And we don't do it intentionally. I know, I do it too. We don't do it intentionally, but things will create a condition so it perpetuates it.
Yeah, it's awful.
And then even things like saying, I'm going to put myself in bed at 8. And
I'm going to force this. I'm going to control it. That's me.
You can't do it.
Because true story, 2 weeks ago, I was like, I hadn't had insomnia in years. And all of a sudden, I'm like laying there going, I was getting ready to go to bed. I'm like, I'm tired. And then all of a sudden, I was like, I'm awake. Oh, shit. I got so much to do tomorrow. And then it all of a sudden goes into this whole, I must sleep. I have to sleep. I am not good at sleeping. And then it was like and I'm like, okay, if I'm not sleeping, nobody else in this house is going to sleep. So I go wake my husband up. And Matt's, oh shit, what? I'm like, I need you to go sit on the couch with me because I can't be alone and not be sleeping. And he's, are you kidding me? I'm like deep into sleep. And I'm like, so I ruin it for other people. It was horrible.
I have early morning awakening for the 5 a.m. flight out of town insomnia. So if I have to catch an early flight, there is no way. I'm asleep, but I must be up every hour.
And I think I'm checking the watch every hour. Is the alarm going to go off? Is the alarm?
Am I going to miss it? Am I not going to make it on the? Yes, all of it. It's terrible.
So we just talked about insufficient sleep, insomnia, and then the third really big thing is sleep apnea, also extremely common. Yeah. When I started in medicine, they used to say 5 to 10% of Americans, and now it's probably a lot higher. Part of that has to do with in the past several decades, the obesity and overweight epidemic has just worsened. So sleep apnea is linked to being overweight or obese, but you can also be normal weight and have sleep apnea. But we see it's just probably more like 20% or even 25% of people have some degree of sleep apnea. A lot of them, and what sleep apnea is just basically abnormal breathing during sleep. So you fall asleep, you might be snoring, and you're having trouble getting air in and out. And then some people just, their throat closes off and they're just
Is
not
that
breathing.
a structural issue?
It's a structural thing and related to weight. So the more weight and the thicker someone's neck is, there's some anatomy to it, but there's also weight related. But like I said, there's also people that have, so if you're heavy, I always tell my patients, like, okay, let's talk about what you're doing for exercise and how you're eating. We're going to diagnose you with sleep apnea and get you treated, which is going to make you feel like $1 million because they all feel tired. I tell people, you go to sleep and it's like someone comes into your house and it's basically strangling you every other minute during sleep.
Oh,
and you're
that
not
sounds
breathing.
horrible.
I know.
Okay.
And
it makes it dramatic.
Exactly.
Definitely.
I'm like, your heart rate's going up, your blood pressure's going up, your oxygen's drifting down, your brain's not getting oxygen, your heart's working harder, and you're doing this all night long. Some people do it every minute during sleep. Some people do it every other minute. Every other minute is 30 times an hour is severe sleep apnea. And we really worry about those because they have a higher risk for heart attack, stroke, dementia, and heart failure, we think. And so identifying them and treating them is really important for those things. But most importantly, if you're just dragging all day and tired, and if you're doing something like driving a bus, go back to the bus driver, you really have to be awake and alert during work hours. One of the reasons I really transitioned well into sleep from critical care was because suddenly I was seeing patients, diagnosing them with this problem, putting them on a sleep mask, and they'd come back and be like, oh my God. I had one guy, young guy, 30-year-old, he said, I just feel like I came out of a fog. I've been in a fog for like years.
Oh, wow. Yeah.
He was not falling asleep when he came home from work, so he's playing with his kids more. He started going to counseling with his wife because they were having trouble. Like everything in his life, he was doing better at work. Everything in his life got better. So that's an amazing story.
I love that.
But I even had an 89-year-old person that came in and they were sitting there looking like they were like demented. I thought they weren't talkative. They were just sitting there with a blank gaze. We tested that person and put them on CPAP and they came back chatty, like a different person.
I love that.
So just getting better sleep and getting more oxygen to their brain possibly is that. And that was such a difference from being in the ICU where, yes, there were a lot of good things that happened in saves, but I don't remember those as much as the hard ones.
Yeah.
And here I felt, wow, like all the time people are coming back and they're feeling fantastic.
And you also, too, are an example. Like you're there going, hey, what about let's talk about how you can improve upon your muscle or working out. So are you offering those things because you are a real life example of that?
Yes. So when I first came here, I love the idea that our offices were right next to the summit, the workout area. I was like, oh my God, we need to have a program. They do have programs that we direct, but my vision was like, I'd be in charge of it and I'd be like doing the exercise stuff with people. We do have pulmonary rehab, which is basically taking people with lung diseases and even sleep apnea and just putting them through regular exercise. Very simple things to begin with, but it makes them feel so good.
Everybody feels better after they move. You do your morning ritual
Yep.
and I go swimming and I always feel better. Yes, so please work out.
Get outside.
Get outside. Yes.
This is Montana.
Yes, and I want to hear about your Ironman. Like, what upcoming competition are you doing?
Okay, no, I don't do Ironman anymore. I
don't?
do long distance cycling though. I'm going to Thailand, and I'm riding from Bangkok to Phuket, which is I think about 500 miles.
Oh, wow.
Yeah.
That's amazing.
And I'm doing that for the Challenge Athletes Foundation. So pretty much every year or every other year, I do some kind of event that is a fundraiser for this organization, Challenge Athletes Foundation. I've been involved with them for over 30 years, fundraising for them. And they just have the most beautiful stories about people with physical disabilities getting equipment so they can get back into sports or into sports. And because medical insurance doesn't cover like running
And those
legs.
things are expensive. Or even
Right.
having a special wheelchair to adapt and be on the road and a racing wheelchair.
And we
or
have the Dream
something.
Adaptive up here, who I still haven't gotten in touch with, but they have worked with Challenge Athletes Foundation, and we've all seen the Dream Adaptive
We'll connect you.
athletes up there.
Yes.
On the mountain.
Julie's coming on the podcast here soon.
Yep.
So, yes, that's what you should definitely get involved with that. That is wonderful.
Yeah, so my Ironman days are over. Those were.
But you have
it was
amazing
mental
races coming
I'm
up.
telling you, I think it was part of my coping. It was. That's how I coped with what my job was. I needed to go for a 2-hour run.
I think it's a great way to cope, but that in between has to be addressed.
So I also did.
I love that.
I also did 1,000 days of running.
Oh, wow.
So this is crazy. Yeah, it sounds neurotic, but it is true. It was all therapy. I remember I was at some event and some guy that I did not think was a runner. It was a cycling event. He was running and I'm like, what are you doing? And he goes, I'm going to officiate someone's marriage in a few. So I've decided to run every day until there because he wanted to lose a few pounds. And I'm like, a running streak. And so I'm like, I'm going to do that for the next 3 months. I heard 100 days, but I think he did 90 days. And at the end of my 100 days, I was on like day 96 and the Boston Marathon bombings happened.
Oh, wow.
And I was just like, oh my God. I had run Boston before in 2004. And the bombing was 2013. And I immediately, I don't know why, but I reached out to people that were Ironman triathletes who had done Boston. I'm like, I think we should go back and run Boston next year. And I remember I sent the text thinking, oh, everyone's going to be like, oh, no, too soon. And all 3 of the other women were immediately like, I'm on board. Yes, we're going to go.
Wow.
So I made these T-shirts that say, I run for you. That's all it said. I run for you. And we went back to support the town, the sport, and then, of course, the people of Boston and the people that were hurt. And some of those people ended up getting prosthetics from the Challenge Athletes Foundation.
Oh, that's great.
Yeah. And so can I tell you so it said Boston 2014. So I run for you. And I don't know how many people were like, where did you get that T-shirt when I was there? And I had a cop come up to me and said, thank you. Thank you for running for me. And it was just like, it was so, I know.
Oh, that's wonderful.
That was amazing. So the first year of my running streak, I ran 7 miles a day.
Wow.
Got it.
The second year, and it wasn't every day. It was it was every day, but it wasn't 7 miles every day. One day I might ride 10. One day I ran 50, I did a race. And second year I ran 6 miles a day. I had all the numbers. This is why I do endurance sports, because I can't get out of my own head. And then the third year, I was starting to get a little less interested in the project because other people were doing running streaks. And so I found myself just doing very short runs, like 2-mile runs. But I can tell you too, most of that, I also ran a different every time I ran a different course. Like I didn't do the same thing over and over again.
Oh, okay.
Yeah.
Maybe part of it, but I'd make sure and I was going all over San Diego. I'd go to canyons I'd never heard of. I'd run at night. I'd run on call.
That would be the only way to keep my interest too, because there's all
too boring, right?
Yeah.
But it was but I think it was mostly the running streak was inspired by the bombings, by that terror attack. And then the way my friends and I just were like, we're going to be there next year to support the race and the people. And that was just
So do you go every year? No, but it's amazing.
I don't run marathons anymore. I did a few halves this past year, but now mostly I'm doing cycling.
Do you have a
crazy
group?
cyclist.
Do you do a group?
So I have, it's funny, I have a few groups. I have a group here in Kalispell that I ride, mostly mountain biking, and it's very social. We'll go, and then we'll stop a little and talk and eat, and then we'll go a little further. And then I have a group that I just went to Mallorca, Spain to do some cycling with, and they're the people from San Diego some of them were racers, and I'm actually just going to see them this coming week when I'm in San Diego. And some of them are going to Thailand.
Wow.
So
Nice.
You're amazing.
You are.
You really are. I'm so impressed by you. We came to the last 3 questions of the podcast, and Kate, you're up.
Okay. If you could go back to your medical residency and have one long conversation with yourself, what would be the focus?
I think knowing the whole thing would be looking at burnout is like being able to recognize what's happening. And then I think 2 is making sure I had the tools to deal with it or to make the change earlier. But I think that would be easily the most important thing.
Yeah.
And it could be that I also really believe change is for all of us, it's so important. And change is not quitting, it's changing. And that's my sister,
yes.
Diane. My sister taught me that.
I love that. Our second question is a fun one. If you had a superpower gift that you could use on patients in the hospital, what would it be and why?
Okay, this is silly.
I love it.
But forever, I've always said, I wish we had a scanner or like a doorway that you just walk through, Star Trek-y, and it would just spit out a list of everything you had wrong with you. Because when you think about coming into the hospital or even coming into the doctor's office, we get the history, then we start ordering tests. Then some of them are blood tests, some of them are CT scans, some of them, and the amount of time it takes, if you're an outpatient, it can take weeks to get your sleep study results
You're
back.
sitting there like nerve-wracked.
And if you're in a hospital, it could be days or at least a day or two until we're like, okay, now I know what you have. Like we don't always know from the beginning just based on your symptoms. It could be something completely different. It's crazy. So my I wish there was that thing. Somebody can
A portal.
Someone can
Star Trek portal.
A portal, yeah.
Yes.
Where you just
Giant
walk through
scanner.
it, and it'll be like hangnail, enlarged tonsils.
Do you think it's coming? Do you think one day we'll have that?
So strangely, there are certain ways to look at the body, and without being too nerdy, energies and makeup that you possibly could. It's the same as like taking blood and seeing that your cholesterol's high.
Right.
Like, why can't somehow we
Like read
I
your
think
body
it's coming.
energy, like a thermoscan.
Yeah.
And
Yeah.
okay.
Yeah.
Yeah.
This is
So-
a little wrong color.
somehow to make everything diagnosable without actually invading the patient. No
Poking
blood
people.
draws.
Yeah.
No.
Oh, I like that idea,
No
too.
surgery. Just
It's really fascinating, all the stuff that's come out of Cambridge, out of Princeton, where they're looking at quantum health sciences and what they're able to do, even as looking at energetic sources coming from various areas of the heart, and they can actually measure the neurochemical and the biochemistry in the body. And I'm a big nerd. If I could have done life all over again, I probably would have been a researcher in that field, because I think it's emerging, it's coming. I think there will be tools. We already have smart tools.
tell them I thought of it first.
Okay, I'll say you were the one. You were thinking of Star Trek. Yeah.
We didn't. Yeah, that's another thing. All the wearables for
Yes.
sleep too. So all these things are really interesting, and
Amazing.
they're getting better and better all the time. Non-invasive way to just measure your heart rate and your oxygen, and even sleep. It's crazy to think that something on your wrist can tell if you're sleeping, and the way it does that
Heart
is
rate, or-
it looks at your heart rate, because in some certain types of in REM sleep, for example, your heart rate is very erratic. It's not regular. It's a little erratic. It speeds up and it slows down. And the other thing that's silly, but if you're in deep sleep, you're also not moving. You're not doing this. So if it detects you're not moving and the heart rate's erratic, it's, that's deep sleep.
Yeah.
And that is getting better and better, those little wearable things for sleep.
Do you do anything with HRV, heart rate variability?
I'm aware of it, and I don't really utilize it so much right now. Most of the stuff that I'm doing is dealing with sleep apnea and like insomnia, and also chronic respiratory failure. I think that's more for like wellness medicine, which, by the way, that all the way along the line of being a critical care doctor and seeing so many sick people, the idea of doing wellness medicine, like taking people that
I can
want
see
to
you doing
focus
that.
on wellness,
Yeah.
that's where it would
I
be
think
really
you'd be
interesting.
amazing.
Yeah.
Because, I mean, I interviewed Dr. Porter, who was TBI specialist and Tom Brady's doctor, and he was talking about all the things that they're doing to blast out HRV, and they're doing all these measurements, and they're seeing all these things that have to do with your pancreas, and just with HRV alone, because it's looking at the stress, the internal dialogue with your parasympathetic system versus your sympathetic system, and how it's impacting the organs.
They have such great studies
So
too,
much
just
stuff going on.
on professional athletes
Crazy.
and sleep
Yeah.
patterns, and high school athletes and
Yes.
sleep patterns, and it is actually really
You should
exciting.
I can see you doing so many things with that.
I think also too, having people that are really motivated to make changes for wellness is got to be wonderfully
Yes,
satisfying.
and you probably bring your energy, you're the way that you think. You probably give that to people and inspire them to think more in that
hope
mindset.
so.
You do,
That's lovely.
yeah, you do. Kate, last question. Sorry.
If you could pass the mic to a Montana woman to share their story on the IWD406 podcast, who would it be and why?
It's pretty easy. So we talked today about exercise, and I talked about all of my endeavors, and then we also talked about sleeping. And the third pillar of good health is eating right. And I met Anna McCabe, who owns Farm to Fork, Montana, which is, she's a completely plant-based. She's out of Big Fork,
Interesting.
and her
Nice.
food is absolutely amazing. First of all, it's hard to get plant-based food in our community. Everything, if you go to a restaurant, it's hard to get something that's completely
Yes,
plant-based. And so I came across her at a farmer's market in Big Fork, and I had one thing that she made. And what she does is she has a menu from, I think it's May until December, every other week, and it's just you order and then you go pick up. And her food is incredible, but she's incredible. So the food is amazing. She is really motivated, and we've been trying to work on a scheme to help educate providers about the benefits of plant-based eating, and then our community as well. So she's just so enthusiastic. Every time I talk to her, she's like, hey, what do you think if we do this or that? And so I totally support her. She does all of her cooking out of her kitchen, her workplace kitchen, works her ass off.
Oh, yeah, I'm sure.
And the food is
I like
amazing.
that idea too. So you can order and then you take it home and
take it
cook it and like that?
Yes, and,
Okay.
and I can tell you,
Nice.
I'm not. I hate to say that I don't hate, but I am not really that interested in cooking. I've never been a cook. I guess because I've been busy being a doctor and also doing too much exercise,
Yes.
over exercising. So pretty much from, I would say, May to December, I'm pretty much just eating Anna's food.
Oh,
nice.
I order a few things on the menu and then it lasts me for another week or two. And
Really?
So, yeah.
I love that. And I wonder if she has it available for
sounds
like
so-
families, like a family
She
of
has catering. She has a catering business.
She does, okay.
But the weekly thing is how I order from her.
Oh, I love that. This is going to be, I can't wait to talk to her.
Yes.
Well,
She's amazing. Amazing.
Thank you so much.
Thank you so
thank
much.
you.
This was a
for being
great
here, Deb.
conversation. You need to come back.
I'd love to.
I would love to do a forum for bringing in health care providers, practitioners, and have a full-blown
Yes.
conversation about just everything, about women's health, because we need to have that.
Right.
It's so important. And I don't know, I can see something really amazing coming out of it. So I would love for you to be a part of that.
I'd love
We
to
could
be
have a
part of it.
big roundtable discussion.
Yes. Awesome. Awesome. Thank you
Yes,
so much.
thank you so
Thank
much.
you, ladies.
All right.
Oh my
A special thank you to our podcast guest. You can find all of her links in the description of this episode. If you like what you heard, please hit subscribe. You will be notified of future podcast guests. Follow us on our social media platforms and stay tuned for our next podcast chat with an amazing Montana woman.